Episode 2. Clinical Cardiology, Decision-Making and Red Flags. Chapter 4. Sinus node artery anatomy and avoidable ischemic injury. Clinical context. The sinus node artery supplies the primary pacemaker of the heart and is frequently overlooked during diagnostic and interventional procedures. Ischemic injury to the sinus node is commonly unrecognized at the time it occurs and misattributed later to drug effects or intrinsic conduction disease. Most sinus node injuries are iatrogenic and preventable. Bradyarrhythmias following coronary procedures often represent unrecognized sinus node ischemia rather than transient vagal phenomena. Anatomical and physiological trap zones. The sinus node artery arises from the right coronary artery in the majority of individuals and from the circumflex artery in a significant minority. Its course is variable and often tortuous, traversing the atrial myocardium with limited collateralization. Perfusion of the sinus node is highly sensitive to brief interruptions in flow. Even transient ischemia may result in persistent sinus node dysfunction due to limited regenerative capacity. Anomalous or dual sinus node arterial supply creates false reassurance during angiographic assessment. Pre-procedure red flags. Planned interventions involving the proximal right coronary or circumflex artery mandate explicit identification of the sinus node artery. Baseline sinus bradycardia or sinoatrial pauses increase vulnerability to ischemic injury. Failure to visualize the sinus node artery before proximal vessel manipulation represents a planning error. Assuming redundancy of atrial blood supply without confirmation is unsafe. Proceeding with proximal vessel intervention without documenting sinus node arterial anatomy increases procedural risk. Intra-procedure catastrophic triggers. Balloon inflation or stent deployment across the sinus node artery origin compromises perfusion abruptly. Plaque shift during proximal right coronary intervention may occlude the sinus node artery without angiographic warning. Guidewire-induced trauma to small atrial branches is often unnoticed but clinically significant. Prolonged hypotension or pressure damping during engagement worsens ischemic susceptibility of the sinus node. Post-procedure silent killers. New onset sinus bradycardia or sinoatrial block following intervention is frequently misattributed to medications. Delayed onset sinus node dysfunction may appear hours to days after the procedure. Transient pacing responsiveness does not exclude permanent nodal injury. Failure to correlate rhythm disturbances with recent coronary manipulation delays definitive management. Documentation that saves or sinks you. Absence of documented sinus node artery anatomy implies lack of awareness. Describing post-procedure bradycardia as expected or drug-related without anatomical consideration weakens defensibility. Failure to document informed risk discussion regarding conduction disturbance increases liability. Clear documentation linking rhythm changes to procedural anatomy guides appropriate follow-up and pacing decisions. Never taught scenarios. Persistent sinus node dysfunction after otherwise uncomplicated right coronary artery stenting. Sinus arrest following circumflex intervention in left dominant systems. Delayed requirement for permanent pacing after transient post-procedure bradycardia. Mislabeling ischemic sinus node injury as age-related degeneration. Guideline anchors. European Society of Cardiology Guidelines on Cardiac Pacing and Cardiac Resynchronization Therapy, 2021, Section 4.2, Paragraph 1. American Heart Association Scientific Statement on Bradyarrhythmias and Conduction Disorders, 2018, Section 3.1, Paragraph 2. American College of Cardiology, Expert Consensus on Complications of Coronary Intervention, 2020, Section 6.3, Paragraph 4. Chapter 5. Papillary muscle variance causing acute mitral regurgitation. Clinical context. Papillary muscle integrity is essential for mitral valve competence, yet papillary muscle anatomy is frequently underappreciated during ischemic syndromes and procedural planning. Acute mitral regurgitation resulting from papillary muscle dysfunction or rupture is often misdiagnosed as pulmonary edema or cardiogenic shock of unclear origin. Papillary muscle variants determine vulnerability to ischemia, mechanical failure, and abrupt hemodynamic collapse. Most catastrophic presentations occur not in known valvular disease, but during acute coronary events or peri-procedural periods. Anatomical and physiological trap zones. The posteromedial papillary muscle is typically supplied by a single coronary artery, most commonly the right coronary artery or the circumflex in left-dominant systems. The anterolateral papillary muscle usually has dual blood supply and is relatively protected. Anatomical variants include bifid papillary muscles, accessory heads, elongated muscle bodies, and abnormal chordal insertion. Single supply dependency creates extreme susceptibility to ischemia, even with transient flow compromise. Papillary muscle ischemia leads to tethering and regurgitation before frank rupture occurs. Pre-procedure red flags. Inferior or posterolateral myocardial infarction increases risk of papillary muscle ischemia. Sudden onset pulmonary edema with preserved left ventricular systolic function suggests acute mitral regurgitation. New systolic murmur may be absent or soft despite severe regurgitation due to rapid pressure equalization. Failure to assess papillary muscle anatomy on echocardiography represents a diagnostic omission. Assuming chronic mitral regurgitation in an acutely unstable patient delays life-saving intervention. Intra-procedure catastrophic triggers. Transient ischemia during coronary intervention may precipitate acute papillary muscle dysfunction. Guide catheter damping or hypotension disproportionately affects single-supply papillary muscles. Reperfusion injury may worsen mechanical instability of already ischemic papillary tissue. Failure to anticipate acute mitral regurgitation during inferior MI intervention leads to delayed recognition of shock etiology. Post-procedure silent killers. Partial papillary muscle rupture may present with delayed hemodynamic deterioration. Mitral regurgitation severity may fluctuate, creating false reassurance during transient stabilization. Pulmonary edema recurrence after apparently successful revascularization should prompt reassessment of mitral valve apparatus. Delayed surgical referral worsens mortality once papillary muscle rupture progresses. Documentation that saves or sinks you. Failure to document papillary muscle assessment on echocardiography implies incomplete evaluation. Describing shock as left ventricular failure without addressing mitral competence weakens clinical reasoning. Absence of documented discussion regarding surgical urgency increases medico-legal exposure. Clear linkage between coronary territory, papillary muscle supply, and regurgitation supports defensible decision-making. Never taught scenarios. Acute severe mitral regurgitation without a loud murmur following inferior myocardial infarction. Papillary muscle ischemia causing intermittent flash pulmonary edema. Delayed papillary muscle rupture days after apparently successful reperfusion. Misdiagnosis of acute mitral regurgitation as pneumonia or fluid overload. Guideline anchors. European Society of Cardiology Guidelines for the Management of Acute Myocardial Infarction 2017, Section 7.6, Paragraph 2. American College of Cardiology Expert Consensus on Acute Mechanical Complications of Myocardial Infarction 2019, Section 3.1, Paragraph 4. American Heart Association Scientific Statement on Acute Mitral Regurgitation 2020, Section 4.2, Paragraph 1. Chapter 6. Left atrial appendage morphology and embolic unpredictability. Clinical context. The left atrial appendage is the dominant source of thromboembolism in atrial fibrillation and atrial cardiomyopathy. Risk assessment based solely on clinical scores underestimates embolic potential when appendage morphology is unfavorable. Embolic events frequently occur despite guideline concordant anticoagulation when appendage anatomy promotes stasis. Procedural and post-procedural strokes often reflect unrecognized appendage-specific risk rather than anticoagulation failure. Anatomical and physiological trap zones. Left atrial appendage morphology varies widely, influencing flow velocity, shear stress, and thrombus formation. Complex multi-lobed appendages create low-flow recesses resistant to effective anticoagulation. Narrow orifice appendages with deep distal lobes promote stasis despite adequate left atrial contraction. Pectinate muscle density and trabeculation increase thrombus anchoring potential. Appendage orientation relative to the left atrium alters washout during atrial systole and diastole. Pre-procedure red flags. History of embolic stroke with low or intermediate clinical risk score suggests anatomy-driven embolism. Inadequate transesophageal echocardiographic characterization of appendage morphology represents an assessment gap. Assuming absence of thrombus on a single imaging plane is unsafe in multi-lobed appendages. Proceeding with cardioversion or ablation without detailed appendage evaluation increases embolic risk. Reliance on anticoagulation alone, without anatomical consideration, constitutes incomplete risk stratification. Intra-procedure catastrophic triggers. Catheter manipulation within the left atrium may dislodge unrecognized appendage thrombus. Rapid rhythm conversion alters appendage flow dynamics and may mobilize pre-existing thrombus. Incomplete appendage occlusion during device placement creates residual thromboembolic risk. Air or particulate embolism risk is amplified in anatomically complex appendages. Post-procedure silent killers. Delayed embolic stroke may occur days after apparently uncomplicated cardioversion or ablation. Transient neurologic symptoms are often dismissed as non-embolic events. Subtherapeutic anticoagulation during peri-procedural transitions increases vulnerability in high-risk appendage morphologies. Residual leaks after appendage occlusion devices maintain embolic potential despite procedural success. Documentation that saves or sinks you. Failure to document appendage morphology implies incomplete embolic risk assessment. Describing anticoagulation as adequate without anatomical correlation weakens defensibility after embolic events. Absence of documented imaging quality and limitations invites retrospective criticism. Clear documentation linking appendage anatomy to procedural planning supports risk-informed decision-making. Never taught scenarios. Embolic stroke in paroxysmal atrial fibrillation with low CHA, 2DS, 2VASC score due to complex appendage morphology. Negative transthoracic echocardiography masking appendage thrombus. Stroke after successful cardioversion attributed incorrectly to anticoagulation interruption alone. Residual appendage flow after occlusion device implantation causing late embolic events. You've been listening to episode 2 of Clinical Cardiology, Decision-Making and Red Flags, available on Amazon. Chapters 4, 5, and 6 from Section 1. In total, there are 14 sections covering virtually complete clinical cardiology. Every disease, condition, and procedure analyzed and explained medico-legally to help you identify and avoid red flags. Next episode continues with the next 3 chapters from Section 1. You are tuned to Red Flag MD. Subscribe, stay warned, stay safe. This content is for educational purposes only and does not constitute legal advice or establish a standard of care. Consult qualified legal counsel for specific cases.